So what we can do in the ICU for preventing the development of antimicrobial resistance. So there are two major points where we can act on theoretically. So can we withhold administration of antibiotics until confirmation of infection, as recently proposed in an editorial in JAMA? So who knows, but this is quite risky and there's a lot of controversy on this issue, and because you want to be sure that your patient is going to be safe if you withhold antibiotics, right? So probably the point that makes sense the most is guided or reducing the length of antibiotic treatment. So you have to take in mind that if you administrate too short course of antibiotics, you could have the risk of no bacterial eradication, and if the treatment is too long, you will face the risk of developing MDRs, toxicity, and increased cost, right? So procalcitonin could help us in this regard. PCT is secreted by the thyroid cells in healthy status, but when an individual faces an infection, it is secreted also by extrathyroidal tissues. The normal levels in healthy individuals are very low, and it is released to the circulation very promptly following infection, bacterial infection, and it has a convenient half-life for being used as biomarker. The levels of PCT drops each day, and that 50% each day following disease resolution. So this is the kinetics of PCT compared with other biomarkers, and you can see here how levels are decreasing with disease resolution, with infection resolution. So the FDA released a test from brands to quantify PCT levels as a useful tool for guiding antibiotic withdrawal in either lower respiratory tract infection and sepsis 2 years ago. So I like a lot this meta-analysis because, you know, this analysis from Lam et al. It was in Critical Care Medicine last year. So they analyzed all the available evidence on PCT for guiding either initiation, discontinuation, or and the studies including both strategies, right? So they observed that just those studies designed specifically for discontinuing antibiotics provide benefit for either mortality and reducing antibiotic duration. So, and with mixed strategies provide a benefit for antibiotic duration reduction. So these are the results. The combined odds ratio for predicting mortality was protective in this meta-analysis for those strategies designed for cessation. What about antibiotic duration? The results were protective, reducing the duration of antibiotics in those strategies designed for antibiotic discontinuation, or in the mixed strategies designed for initiation and discontinuation. So it seems that it makes sense using PCT for antibiotic cessation. I'm going to provide some evidence coming from the available clinical trials specifically designed for antibiotic discontinuation using PCT. This is a trial coming from Nobre, published in the Blue Journal. This is a small trial, but they evidence that the reduction of antibiotic duration using PCT. And they also observed a reduced stay at the ICU with no repercussion on mortality. This was done in septic patients. This German trial was performed on critically ill patients, and they demonstrate just the same, that guiding therapy with PCT, you are able to reduce antibiotic duration and intensive care stay with no repercussions or no negative effect on the success of treatment. This study was also specifically designed to discontinue antibiotics in ventilator-associated pneumonia. The results are very similar. You will have more antibiotic-free days if you guide your decisions using PCT. But probably the most important trial, specifically designed for antibiotic discontinuation, is this coming from the Netherlands. So this is the largest in size, and they demonstrated that there is a reduction in antibiotic duration in this trial and a positive impact on mortality. So I have to say that this trial was performed in a country with a good policy of antibiotics like the Netherlands, but I wonder what would happen as a result of this study in other countries with different policies. Probably the probability of getting even better results is higher, right? So when you are going to make a decision on antibiotic discontinuation, you have to use your head first, right? So you have to take into account clinical evolution of the patient, and you need to ask yourself if the source of infection is controlled, if you have a localized infection with no expression of procalcitonin in the periphery, if organ failure is solved, what kind of microbe you have, and probably you will need to repeat PCT evaluation along time, right? So if you use common sense and procalcitonin, it could work. So in conclusion, procalcitonin used for discontinuing antibiotics is safe and could even reduce mortality, reduce antibiotic days, and at the long term, it could be a very useful strategy to prevent emergence of antimicrobial-resistant pathogens. For sure, we need EPI studies to evaluate the impact of these strategies on the microbiology of your ICU or our ICUs worldwide. You already know that there are a lot of different protocols proposed for antibiotic discontinuation using PCT, but this very recent paper is a consensus paper for the use of PCT for guiding antibiotic administration and discontinuation in either sepsis and lower respiratory tract infection. So they unify the criteria for using PCT, proposing one single cutoff and drop by 80% from the peak. So this protocol could simplify a lot application of PCT for antibiotic discontinuation. Finally, I'm an immunologist, and I cannot resist to say that probably the future should be the combination of biomarkers. And we published this paper, this is for sepsis diagnosis, the combination of PCT with an immunological biomarker like HLA-DR, improved sepsis detection. We want to test this notion for guiding antibiotic discontinuation. It's just the same here. We found recently that there is a specific immunological phenotype of pneumonia, which is lymphopenic pneumonia, with twofold risk opportunities to die than if you don't have lymphopenia. So, is the efficiency of an antibiotic the same in an immunocompromised host or a non-immunocompetent or an immunocompetent host? We don't know, so we need to introduce in the equation the immune system. So the future is very exciting, and we will need probably a combination of biomarkers to make better decisions in antibiotic discontinuation in severe infection. So in conclusion, I think for sure that PCT could be very helpful for guiding antibiotic discontinuation, and probably we'll need more studies specifically designed for addressing antibiotic cessation to further support these notions, right? I want to finish thanking everybody working in the surgical and medical ICUs in Valladolid and Salamanca.